Okay, thank you so much. Thank you, Chandak sir. Thank you, Manoj. Uh, I'm going to start and briefly introduce to you what we generally feel about wounds. I think the topic got modified into post-operative or post-closed wounds, but I had prepared this talk basically with generally dressings in viewpoint. So I'll quickly go through. I have only 20 slides, and knowing that it is only 12 minutes, I'll go through it quickly. First of all, just a moment. Huh?
You'll have to click on this slide.
Yeah. Philosophy of dressings. Now, when we apply dressings, we have to understand that dressings are an integral part of treatment. It is not something that is forced upon us, because as surgeons, we have our own inclination towards operating and surgical management. And to manage dressings of wounds or even post-operative wounds is treated as secondary. In fact, that should not be the outlook. Dressings are an integral part of treatment, and they are also the overt face of treatment. Many times what you do inside is not so obvious. Of course, in orthopedic practice, in trauma practice, it is quite obvious because you take a lot of x-rays and the patient sees the x-rays also. But then when the patient comes out of the operation theater, what the patient sees is the dressing. So it's the overt face of treatment. And it is also taken by patients and everybody as an important parameter of standard of care. If a good dressing or if a good dressing is applied and if it is maintained well, then it is taken that your capability to manage medical treatment also is as good. Of course, I have put the definition of philosophy because philosophy turned out to be too heavy a word to utter otherwise. Now, the whole idea is to try to understand that it is technique against tactic. We all learn techniques of dressings, and we all learn how to do a very good dressing with materials, with modern materials, and we have learned from our seniors, and they have learned from their seniors many techniques of dressings. But what is more important is to understand how to tactically tackle a wound in the form of dressings. How do you look at wounds, and then how do you dress them in a particular manner? So tactic would be probably more important than technique. Now, we do dressings for multiple purposes. We may do them for cure, that if you do a dressing of a wound, it will cure the patient of his malady. Or it may be part of an ongoing plan that you are waiting for it to improve, the wound to improve, and then you are going to surgically tackle the wound. Or it may be purely with service insight, like this patient's wound that you see here. Now, in this patient, I have no plan really at present, and I'm going to only do dressings for service purposes. So, in fact, this also invites a lot of tactical management of patient in the form of dressings. So, what do dressings achieve? First of all, I'll give a very broad outline. Dressings achieve a closed milieu. It is closer to the milieu interior. So, in fact, you can control the wound and control the movement or progress of the wounds and the patient's capability to handle wounds with dressings. It also avoids external contamination. There is pain control, and of course, there is aesthetics. You can't leave an open wound and go about, and people will be horrified to see large wounds if they are kept open. So, basically, these 4 points we try to achieve through dressings. Now, dressings, we have understood a lot about dressings from this pandemic also, that what dressings we do are more like masks. And we have progressed from masks, that is the barrier for contamination. We have progressed from masks to PPE kit. PPE kit is more akin to our vac dressings, which are perfectly 100% secured from external contamination. But then I'm not going to talk on VAC. We are going to talk on basically masks, that is dressings which are open to air sort of, but they create a barrier. Now, who will do the dressings? This point I have to stress, because if you notice, there are 5 people who can do the dressings: the surgeon, the assistant surgeon, the dresser, a staff nurse, or ward boy, or for that matter, anybody who is trained in this trade. But then I have particularly put dresser in capital because all the other 4 are also performing the function of the dresser. People who have worked in public hospitals, especially in large tertiary care centers, will know that there is a post of dresser, which is, I feel nowadays it is rather redundant. People don't call themselves dresser anymore. But some ward boys who were better educated and better equipped with the capability of understanding were given the posts of dresser. And they had a very particular role, and that is to look after the dressings of the patients in the wards. Now, as far as I remember, in my residency also, the dresser was not very active, and they had other duties to perform, and they were considered as senior ward boys or almost like staff nurses. But dresser was a very important post, and we all should look at dressing from the point of view of the dresser. Now, facts and myths about granulation, I have particularly put this into action because this slide, because we often talk about granulation as a method of assessing a wound. And basically, when granulation appears, people say now the wound is good or bad. Uh, Look at granulation only as a parameter to assess what you will do next rather than the progress of the wound. In our case scenario, since we are surgeons, we are going to tackle the wound surgically. So granulation basically gives us an idea of the progress of the wound, nothing more than that, I suppose, in technical terms at least. Now, diagnosing granulation, I will not go into detail because this CME is not on that particularly, but you can see from the slides how the granulation improves. The lowermost wound is not the part of the same series, but that is the granulation we try to achieve. Now, why change a dressing? Uh, Basically, for these reasons, that there could be soakage, could be infection. Now, there has been a long duration since the last dressing, and you also will change or remove the dressing when there is the use of the dressing has ended. Look at the top slide here. Now, this wound is slightly soaked. This is about 3 days after applying the dressing. Now, this dressing, to manage this kind of a thing, you should not put more layers of padding. Now, there is a misconception that if you put more layers of padding, then the wound will soak into the padding, and externally there will be no soakage, and the wound will be taken care of. But that's not the truth. When you remove this dressing, you realize that there's a large wound which is exudating underneath it. So, tactically speaking, this wound should be dressed more frequently rather than with thicker padding. There is a misconception that if there is no soakage in the outermost layer of the dressing, then everything is hunky dory. That's not true. Let me put it this way: that if you have a dressing that you have put today, and let's say the wound is as exudative as this wound, then after 2 to 3 hours, the innermost layer is already soaked, and there is a redundant soakage, and there is a wet, dirty part of dressing underneath the dressing outside. The innermost layer is already soaked, and it gets slowly and rather not slowly, it gets quickly contaminated, and bacteria and organisms start growing in it very fast. So if you dress the wound after 3 more days, then there is almost 2 hours, less than 3 days, the wound is soaked in dirty tissue and dirty material and dirty dressing. So if you change the dressing after 3 days, or even though the outermost layer is not soaked, then you are creating a sort of a milieu for higher infection. So I think the frequency and timing of dressings is equally important. That if the innermost layer is soaking within a few hours, then the dressing needs to be changed much more frequently. Now, timing of dressings, the need to think about this is basically because we want to ease the visits of the patients. See, if you are dressing a wound today, then you would rather wait for a few more days to dress the next time, so that the patient is more comfortable and comes to your OPD once in a few days rather than every day or twice every day. The other reason is obviously soakage. And but the important reason that we many times do not consider is inspection and planning. Patients do not understand this point so well, even though we might try to tell the patient, look, we have to inspect this wound every 3 days, but the patient wants to come back after 7 days. So you have to stress on this point, that dressing also is important, because we are going to open and inspect the wound, and further planning of treatment depends on that. And of course, when there is end of use, that is the time when you remove the dressing. Now, I'll consider a few scenarios, basically because I'm a plastic surgeon and I come in contact with many orthopedic surgeons who I have to keep repeatedly telling about how to manage a skin graft dressing. I have generally put forward a couple of ideas. You know, tie-over dressing. The tie-over dressing is a dressing in which stitches are taken around the dressing and the long threads are tied over gauze and pad material. Now, this fixes the graft to the base, so it creates an immobilization and the graft stays in place. Also, it gives pressure so that there is no collection under the graft. Now, I could not put a slide of suspension. I'll show you in another slide how to suspend a thigh dressing. Many times we realize that there's a very fat lady with a conical thigh, and you put a bandage on it, put a large padding and bandage on it, and 3-4 layers of Gamgee pads over that. You put a bandage, and the whole thing starts slipping from a few hours from the dressing that you have put. So there is a suspension that I have devised. I'll show you. Basically, it's micropore tapes which are put longitudinally with the hip in extension. They are put longitudinally from the bottom of the dressing right up till the umbilicus. So the whole dressing is suspended by 3 or 4 micropore tapes, and it doesn't slip down. No amount of circumferential micropore taping or dynaplast taping hold these dressings in place. Now, special dressings like for flaps, if you see in this upper picture, we have devised a sort of a bracket on which the heel part rests. There is a slab underneath there's a posterior slab underneath the ankle, and this is basically done for a flap which goes across the ankle from below. Now you also see that there are mixed dressings because when you do a flap or you do a reconstructive procedure, sometimes there is a graft right beside it, either because not the entire wound is covered with flap, or you have grafted the donor area of the flap. In such a scenario, you have a tie over dressing on the graft this way, just beside the flap. Also, if you notice, the flap's pedicle area is very small because this is a perforator based flap. So you have to protect the perforator. Now, this dynaplast tape I have put away from the edge of the flap, because if you put close to the edge here, you might compress the pedicle of the flap. I've only put this to highlight that sometimes the pedicle, they cannot tolerate pressure, and that it is better not to put compressive dressings over it. Tulle Gras, there are certain things that I would like to stress and highlight. One of the things is that most of our junior fellows or assistants will use much less sofra tool than it actually is required. Most often it happens that you ask the person to dress the wound, and he will put the smallest size sofra tool that is needed for the wound, barely crossing the edges. And imagine that this dressing is going to shift a little bit, let's say 1 or 2 centimeters here and there when the patient moves. You may not have to give plaster on that patient, and it is only a simple dressing. And then you realize that the edges of the wound are exposed, and you have a wound sticking to the dressing, and the pain while removing the dressing, or generally a very dirty wound to come with. So for that, we have to understand that there should be a significant more than an inch overlap on the borders of the wound, as well as between the 2 sofra tool sheets or multiple sofra tool sheets that you are applying. This is a very important point. Now, in our residency days, we were asked to save sofra tool because it was expensive and we couldn't get them easily. But nowadays, if you see the sofra tool sheet 10 by 30 costs some 80 or 60 or 80 rupees. But if you do not use it adequately, and if the wound sticks to the dressing and you have to rip it off, then the patient undergoes many more dressings, which is many thousands of rupees cost. So basically, putting in a couple of more sofra tools saves the cost a lot. Of course, I am also particularly keeping a mention on the size of sofra tools available, and 1 meter rolls are also available, which you should use in larger wounds or around the limbs. Some conceptions about povidone iodine. Povidone iodine is an irritant. It's a wonderful antiseptic and antibacterial, but it is also an irritant. So if you keep using it on an open wound for a very long time, then you will see hypergranulation. And this hypergranulation is difficult to treat unless you really surgically treat it with curettage. So even if you have a wound, let us say a sutured wound also, a sutured surgical wound, which is discharging from one point, and if you keep applying betadine to that for, let us say, 2-3 weeks, then eventually you will find hypergranulation there, which you will have to either cure it off or burn away with a chemical or something. So remember that once the necessity to use it as an antiseptic or antibacterial is adequately under control, then stop using povidone iodine in the dressing. Use general dressings, dry dressings. Window dressings, I am only mentioning a couple of points. Fingertip dressing with the cap of an IV bottle on top of it stuck with tape, and a window dressing for a flap or a sutured wound, through which you can observe the dressings. This is again a dressing which is quite useful when you want to inspect the dressings often, but then you also need to give a large dressing every time. This is a pro nata dressing in which you can flip it over every time you want to see the inspect the wound, and put it back when it is when you have to send the patient away. Materials, only a couple of things I will mention. Dynaplast is supposed to be putting pressure on the wounds, and people use it by stretching down and putting pressure on the wounds, thinking that the dynaplast is actually putting pressure on the wound. That is not true. Dynaplast is a stretchable dressing. It in fact stretches out. So once you pull it and put it down on the dressing, it actually expands and the pressure is lowered. So if you really want to put a pressure on the wound, better to use micropore. Of course, we use Dynaplast because of its adhering qualities. Recent micropores and transpose do the same job actually. I will not talk about collagen because that will be managing large wounds for that matter. Now, away dressings. Many of us are come into this situation where patients come to us from outstation, and we have to ask someone else to manage our dressing in the periphery. Choosing a proper medic or a place set up to do these dressings away from your setup is important, because many times you see that because of sending away the patient somewhere else, you get infection and cross infection from the other person's setups. So here you have to choose a place which is not very busy, probably not a public hospital, and an intelligent young person who will be interested in doing the dressings. That will be the best person to go to for such matters. Cross contamination, I will not talk about this. Someone else is, I think, going to talk about this. I will only mention that dressing rooms and minor OTs of almost all hospitals where there is a lot of patient load are also sort of super spreaders of cross contamination. So a thought for that, when you are conducting dressings, make sure that you avoid these places. Thank you.